Hi, welcome to Two Guys in Scrubs. We are Two Guys in Scrubs. I'm Silas Rades.
And I'm Delbert. We're second-year medical students at the University of British Columbia, and we started this podcast to share what it's like going through medical school, discuss medicine, and pretty much anything else.
Bum-ba-da-bum. Please be advised, Two Guys in Scrubs is for educational and entertainment purposes only, and the views expressed do not reflect the views of our program or supervisors necessarily. I put a little twist on it this time.
I liked it. Yeah.
And we're back, episode 3.
Yes.
Welcome.
Thank
If you're
you.
listening out there, welcome back to episode 3. Welcome, Delbert. Yep. Welcome, Silas.
Our non-existent listeners, as you always say.
Yeah. Who knows? By this time, it might be building.
Yeah.
And but I'm very excited for this episode because we decided this episode we're just going to talk about our recent experiences doing something in the UBC medical program called CSI. No, not the show from the 90s where they. Do you remember that show?
Yeah, I think it's called Criminal Scene Investigation.
Yeah, something like that. Maybe it's Crime Scene Investigation.
Oh, okay. Yeah, I do remember.
All those good old cheesy crime shows from the early 2000s. But it is not like that, although it does involve an element of detective work, I would say.
Yes.
But without much ado, yeah, it's called clinical skills integration. So just as a quick overview for the listeners, in the preclinical years in UBC Med School, year 1 and year 2, before we start doing our rotations in year 3, we have clinical skills training. Mm-hmm. And, we have small group sessions with tutors. We learn how to communicate with patients, and then we build up into actually doing focused history and physical exams. We learn how to do cardiovascular exam, peripheral artery exam, whatever it is, gastrointestinal exam, etc. And now in second year, we have these 2 sessions where they're called clinical skills integration, where we actually go see patients that are admitted to the hospital, real patients. Mm-hmm. We get assigned a patient in the morning. We have to go to the hospital. We're totally alone. We're not being accompanied by an attending or by a tutor or anyone like that. We have to kind of tell the nurses we're there. We go see the patient. Hopefully they're there and they're not out for tests. Hopefully they are awake. Hopefully they are amenable to talking to a med student. And then we have an hour. We have an hour to do a full history and physical with them. And then we have to go report to our tutor. So this is kind of like it's a new experience for us in second year. We haven't, when you do this for this first time, you would have never necessarily done something similar previously unless you're doing some shadowing in the hospital and you were given that autonomy. So yeah, that's the overview of what CSI, clinical skills integration, is. And we thought we'd spend an episode reflecting on our experiences because we both finished both of our sessions recently. And we thought we'd discuss the cases because I've been so curious to what Delbert's cases were, but I told him that do not tell me anything until we until we get the mics out and start recording the podcast. So how does that sound to you?
That sounds good. And I think just to add on to that point, it's not only about the clinical skills and applying our clinical knowledge to real patients, but it's also just the logistics and physical setting of being in a real hospital ward, right? It's so different. I remember the first session I had up at St. Paul's, I was honestly just like a deer in headlights is how I felt. I was sort of loitering around the nurses' station for almost 10 minutes and everyone was just ignoring me. So then I went up to one of the nurses. I built up the confidence to do so, or courage rather. And I just asked her to introduce me to the patient because I wasn't sure if they needed investigations or not, right? I didn't know if we could just barge in. We didn't really get that much instruction. We were just told, show up at this time and start talking to your patient for X time, right? Right?
Yes.
Yeah, so I went there a little bit early because they told us to get there 30 minutes early in case we needed to find spare patients. For instance, if our assigned patients were, for instance, away or asleep or too tired or whatever. So I got there early and then I spent half that time just loitering around. I was so scared. I was like, am I supposed to be here? Everyone just ignored me. It was a bit of a interesting experience, but yes,
Well,
I think
you feel so much like an imposter, don't you?
absolutely.
Like, you know you're there. You know you're not there to benefit anyone. You're not going to be delivering any kind of medical care. You're not in the end going to be helping the patient.
Hmm.
You're not going to be involved in the management of their care. You're not even after going to be talking to their healthcare team
Yep.
about them. You're just this med student who's slipping in under the radar, spending an hour with a patient and then leaving. And you know, as you were saying, as students that have never done this kind of thing before, you feel like a total imposter. And I'm sure that experience was very similar across all the students of kind of being there and being very apprehensive to go talk to the patient. You're like, there's no way I should actually be doing this. That's the feeling.
Yeah. And the ward is busy. Everyone, it feels like nobody has time for you, right? And so I didn't want to ask people to, for help or confirmation or whatnot. I was even worried, like, should I even leave my bag, behind the nurse's station or something? All these little things that you don't really think about when you're preparing for these cases, because, you're trying to memorize whatever schema or differential and symptoms, et cetera, et cetera. But then
Hmm.
actually getting there is is quite challenging as well. But yeah, it sounds like, you had a similar experience in terms of that. Um, my first patient, again, I mentioned it was at St. Paul's. It was internal medicine. He was in for a stomach ulcer. He had had surgery a few days ago. I think it was 4 days ago when I met him. He's 44 years old. And he had several months of what he described as, quote unquote, trouble keeping food down due to progressively worsening stomach pain. He described the pain as knife-like and constantly present and exacerbated after eating food. So these are just classic descriptors of stomach ulcers, right? Localized to a focal point, didn't radiate, and it just got so bad that he became apprehensive of eating. It's not so much he was vomiting or that food was getting stuck in his esophagus, or he was regurgitating the food. He was just so scared of the pain that came with eating that he stopped eating for almost, I think it was 3 or 4 months. He was just getting very minimal Ensure, which is like a liquid meal replacement, right? And so he ended up losing what he says to be 50 pounds over 6 months. And
Wow.
when I saw him, he was just so thin, so what's the word? Emaciated.
I was almost going to say emancipated.
I was about to say that.
Emaciated, yeah.
Very, very thin. He was, he's 6 feet, but you could see straight to just a skeleton, almost very, very thin and worn down. So of
Hmm.
course, when you see a patient like that, you want to rule out malignancy. That's what we're trained to do, at least. And so I asked him about history of cancer, asked him about systemic constitutional symptoms like chills, night sweats, fevers, even early satiety, but he denied all of those. And then I mentioned some of the negatives for other causes of gastrointestinal disease, such as reflux, regurg, GERD, ingestion of spicy or caustic substances, and he denied these as well. It seems to be his first episode. He's never had this before. Later on, I learned that he had had a hip fracture several years ago during work he works in construction, and he never went to the doctor for it, but it just kept getting worse and worse. So he was popping NSAIDs every day, maybe 3 or 4 a day to control the pain. And he did that for several months. And we know that
Mm.
NSAIDs contribute pretty heavily to the pathophysiology of ulcers. Do you remember how?
This isn't a very astute answer, but I believe it's a prostaglandin related mechanism.
Yep. Yep. Yeah.
That
So
the reason, of course, why it's not astute is because NSAIDs are a antiprostaglandin, so it's kind of a catch-all answer.
uh-huh.
But I know that prostaglandins are involved some way in creating a mucosal protective layer in the stomach or something of the kind.
Yeah, that's about it.
Yeah.
That's about all I know as well. So, the prostaglandin is important for stimulating mucus production by those goblet cells in the mucosa, right? So anyway, he denied all these other causes of potential gastrointestinal disease. Of course, I also screened him for chest or thoracic and cardiovascular disease, and he denied symptoms of angina or dysrhythmia, cardiac tamponade, pericarditis, things like that,
And is
pancreatitis.
your thinking? Sorry to interrupt. Is your
Hmm.
thinking there because epigastric or even like retrosternal GERD type chest pain or GERD type pain can manifest as a chest pain, or is the chest pain your focal point of asking about cardiovascular disease and risk factors?
Yeah, it's actually both of those. I think whenever a patient comes in with, you know, pain in that general region, you want to rule out,
Hmm.
you know, cardiovascular causes, especially the ones that could be potentially fatal, right? So, fatal arrhythmias, myocardial ischemia, signs of angina, things like that. And my tutor was very good um, and extensive about detailing all those potential causes. And this is actually something we've talked about before, but one of the signs we spent some time talking about is pulsus paradoxus, which is seen in
Hmm.
cardiac tamponade and constrictive pericarditis. Anyway,
Hmm.
it wasn't relevant for this patient, but it was something that we did have to rule out. So, just in summary, it was a stomach ulcer we ruled out, or in terms of history, it was inconsistent with cardiac malignancy and other gastrointestinal disease. He has a history. He had a history of hip fracture, long-term NSAID use, and right now, or at least when I saw him, he was very emaciated, very weak. He was on painkillers, antibiotics, etc., because of his recent surgery. Um, yeah.
Hmm.
What do you think about
Hmm.
the history so far?
And I guess importantly, and it goes without saying, it's the epigastric pain that he's experiencing
Hmm.
seems to be temporally linked to eating, right?
Yes, yeah, and that would make sense, right? Because when you eat, that reflex stimulates the release of stomach acid, and so it makes it worse. So we can
Yes.
localize the ulcer to the stomach rather than, say, the duodenum, which would typically improve with eating.
Yes. Yes. Absolutely.
Hmm.
And I'm just thinking of other causes of epigastric pain or slash retrosternal chest pain that could be temporally linked to eating, like an esophageal
Mm.
etiology, for example, or I don't know whether a gastritis would have a similar effect or not. Were you during this time? Were you considering other gastrointestinal causes other than the ulcer, or because you had the history of NSAID use and you were able to not rule out, but be more confident that it's not a type of malignancy? Were you kind of focusing in on the ulcer here?
I did try to rule out several, I mean, the main causes of gastrointestinal or main gastrointestinal etiologies of epigastric pain. So you mentioned esophageal, and so I asked about reflux, regurg, consumption of spicy things, as well as caustic substances, which
Hmm.
can potentially cause esophagitis. And of course, things like really bad breath or halitosis, as well as the sensation of food getting stuck in your throat. That is a sign of something like a diverticulum or stricture or perhaps even a ring. And those could also be associated with various cancers of the esophagus. I also asked about things like vomiting, distension, constipation,
Hmm.
bleeding in the stool, or
Yeah.
pain with defecation, and he denied
Hmm.
these things. And
Hmm.
so I was pretty confident it was going to be an ulcer. Of course,
Yeah.
given that he just had surgery for an ulcer, but we know that sometimes people get surgery for the wrong reason. But anyway,
And how did you get the history about? Did he just tell you straight up? I just had surgery for a stomach ulcer.
yeah, he just told me that.
Oh yeah, because it is worth noting, of course, and maybe we alluded to it before, but during these sessions we have no access to the patient's chart records, previous
Hmm.
investigations, unless they tell us.
Yep. Yeah.
So we have, we have basically our conversation and physical exam are the tools that we have at our disposal.
Hmm.
Fascinating, because your history was so thorough. I think our pretest probability, not that we're doing any tests, but let's just say our clinical suspicion of ulcer is extremely high. Let's just say he didn't tell you explicitly that he just had surgery for a stomach ulcer, but I think if you take that away, your history, even before physical exam, was quite thorough, and I think at this point you have to entertain multiple causes on the differential, but I think you did a really good job at narrowing in on stomach ulcer as the cause. Just a quick thought, which would be, unrelated to the diagnosis, but when I was just thinking about this, it's a gentleman, right? It was a
Yep.
man.
Yep.
Think about this gentleman's condition. I couldn't imagine having a disease process that makes you fearful of fulfilling basic life necessities.
Mm, yep.
So I couldn't imagine having something where now I'm terrified to eat food,
Yep.
or maybe it's I'm terrified to go to sleep at night, or whatever it is. Kind of this disease processes that impede our ability to just fulfill our basic necessities. So I was just kind of feeling a bit empathetic with him there, because I imagine that's just terrifying. What a terrible situation to be in. My other question would be, if it's been going on for so long, kind of what took so long for him to either seek medical care, or for him to to kind of have to have any treatment. I know he had surgery, but we have non-surgical options for stomach ulcers as well. So did you get any sense from him there about kind of how this was allowed to go on for so long?
Yeah. And this gets into some of the later segments of the HPI, right? So social and past medical history. So this is a person who does not have stable housing.
Hmm.
He's been not really working consistently due to various issues, including, of course, his housing situation, but also drug use and separation from social supports, such
Hmm.
as his family, such as his friends. He is also wheelchair bound, so that limits his mobility. And he seems to be living in a fairly precarious situation. So, for instance, I think it was 20 years ago, he was stabbed 3 times in his upper back, and this led to a hemothorax and collapsed lung. So, all these factors, I think, really made it hard for him to seek care at the appropriate time.
Hmm.
And when I was
Hmm.
getting the history from him, I had a sense that he wasn't giving me the full picture, right? But, he was telling me things, but I suspect things were perhaps, worse, and he was just leaving it out.
Hmm. Hmm. Yeah. So interesting and sad at the same time. Yeah, it speaks to the psychosocial and environmental factors that influence someone's health, because we can do so many things for a person, but if they don't interact with the healthcare system, then we can't do anything.
Yeah, and
And
but
these are
there's only so much we can do, right? He's in for a few weeks, and then he has to be discharged. And then after he's discharged, there's still many things, many perpetuating factors, as they say in psychiatry, or predisposing factors that remain and will not, be fixed by a simple surgery and hospitalization. So,
Absolutely.
yeah.
Yeah. Well,
Do you want to hear the physical?
yeah, I was going to say, give me the, let's hear let's get a physical exam summary here.
Okay. So, as I mentioned, he appeared emaciated, very tired, but was not in distress. So no signs of, say, tripoding or accessory muscle use, diaphoresis. He was conversating well. He was pleasant, cooperative. Vitals were normal. So, for instance, heart rate is 80, resp rate is 16. I didn't measure blood pressure and temperature, but on palpation, the temperature of his skin was normal compared to my own. The main thing that really stuck out to me, of course, there were all these, different, slightly abnormal findings due to his general state of health being so thin and weak. But the main thing that really stuck out to me and everyone else in the group was a extreme and very diffuse venous stasis dermatitis extending from his feet up to, I would say, almost his groin. And it was severe. There were lots and lots of ulcers, and I'd never seen anything like it. It was almost black. It's like deep purple.
Wow.
And it was your classic venous stasis dermatitis with venous ulcers. So these were moist lesions. They were necrotic. It was very striking to see. And I remember when my tutor, or I guess preceptor, came around, helped us with the exam. After that, he took me and the other student outside the hallway, and we just sat or stood for like a minute. He was just looking down, didn't say anything. And then he looked up to us and said, "If you remember anything or take away anything from today, just remember that there are times when we need to be clinicians, have the sharp acumen, make important decisions. But then there's also times that we need to feel because we're humans." And, he was crying, and I could see some tears from his eyes. And yeah, it was a very emotional experience.
Wow. Wow. Yeah, that sounds extremely impactful.
Yeah.
I can only imagine what a rich learning experience, even though it was kind of emotionally heavy, and amazing to hear about the sensitivity of your tutor as well, because we have so much variability in people that are teaching us. Not everyone is willing to be vulnerable with students or provide students with such an important, not just clinical experience, but life learning experience.
Yeah,
and so
it's just
I'm really glad that you had it.
It's just so nice to have that from somebody at this stage of our learning, because we're so impressionable. We know nothing about what it's like to be a physician, and I can't really give much. I don't want to give away my preceptor's identity because anonymity and
Of
so
course.
on. But he did not initially strike me as somebody who would do that. It was a very he was initially very systematic, methodical, very high-paced, high-energy, your classic, internal medicine subspecialist, right? He's like, encyclopedic knowledge, very, very, he was grilling me on pericarditis and cardiac tamponade and things like that. So it was so, it made such a deep impression on me to see him go from that to telling us about, you need to feel, you need to be human. This is very, very important, this is a very critical part of medicine. And the best thing is, or not the best thing, but like, the weirdest thing is that right after that, we went down the stairs back to our CBL rooms, or not CBL, our whatever rooms. There are rooms in
Yeah,
the
and just
hospital,
instructional
yeah,
instructional rooms. Yeah,
for medical students and tutors to do teaching, right? So we went to those rooms, and as we were walking downstairs, we passed by a I guess it was like a newborn ward or something, and it was, everybody was happy there. There were, kids running around and playing. It was just like we just went down one flight of stairs,
yeah.
and it's like the world is completely changed. The mood is completely different. It was so weird.
Fascinating how kind of within a hospital we have every dimension of life and human experience happening simultaneously.
Yeah.
Yeah, it's just incredible. Well, thanks for sharing that experience. It's yeah, it speaks to this. One of the competent. I was having a conversation with someone recently, and we were talking about the competencies that that a physician needs to have.
Hmm.
And I forget what spurred the discussion, but I shared this reflection with them, which was one thing that's not the one thing that's unique about being a physician. It's not limited to practicing medicine, but I would say it's unique about having this role, is that you have to have so many different competencies. And what I mean is competencies in completely different areas. And you need to be able to seamlessly shapeshift or move between these different competencies or even personas, like you were describing.
Hmm.
And for it's not easy for everybody to switch roles and switch approaches so quickly, so seamlessly, and even integrate them together. So that's what I was thinking of when you were sharing this experience with a physician, going from cold cut encyclopedia, linear logic, etc., very clinical, and switching into being emotional, empathic, human, etc. And we need to be able to switch between these roles, and we also need to be able to integrate these roles together. And I think that's it's a unique part about our future jobs.
Hmm.
There are other professions in where your role is a lot more static, and you're not forced to constantly switch between these different roles. So I find that very interesting. That was great. It's a fascinating case. I assume the rest of the physical exam was more or less normal.
Yep. As I mentioned, because of his physical state, for instance, his heart sounds were, faint. His breath sounds were faint. There wasn't a lot of chest excursion, things like that. But that's just sort of expected with his condition.
Mm-hmm. Mm-hmm. Well, hoping the best for him.
Mm-hmm.
Like you said, and I will, without sharing too much, that's a reflection that I had, because on my first day that I did CSI, it wasn't my patient, but one of the students I was working closely with on the same ward, his patient, and then the patient that I saw on my second CSI visit were also had insecure housing, were unhoused currently, and not in the same situation as this gentleman, but we see a lot of these. We see a lot of this demographic downtown Vancouver and at St. Paul's and even at Vancouver General Hospital. There's a good proportion of individuals who are unhoused in socially precarious situations, may or may not have substance use disorders and be struggling in that area. And when they come into the hospital, they're admitted. We can help them to a certain extent, but there's always the question of, okay, we have to get them stable. They will eventually be released. We will eventually discharge them, and then what? And I think that the question, and then what, it doesn't fall under your official responsibilities for a lot of physicians in the hospital. Maybe if you're working in addictions or you're more of a social worker, you will entertain this and then what thought more. But for us, we kind of have to see them go, knowing that we're sending them out back into a precarious situation, and their chances of maybe returning to the hospital soon or just their living conditions once we discharge them are less than ideal, and it's sad. It definitely had an impact on me. I just felt myself being very sad for these people, and it's such a difference that discharging a patient where their whole family is waiting for them on the ward to be discharged, and they're going to take them home and take care of them.
Hmm. It's sort of defeating, right? Because you're putting in all this work, and it's almost meaningless at the end of the day because there's so many other factors that go uncorrected, unchanged, that nobody can really address, at least not at our level or with anyone in our field, really.
Absolutely. Okay. Absolutely. All right. Let me share some of my experience with you.
Sure.
I'm not sure if we'll be able to get through two cases each today, but we'll see how it goes.
Mm-hmm.
Before I give you the case, I'm just going to tell you a little bit about the experience first, and then I'll give you some of the information about the case. So when I showed up a bit early, just because I wanted time to find my patient and to kind of get oriented, and also, build up the courage to actually do this, to have this experience. But I've done some shadowing in first year, and I've been on the wards. I was lucky enough to shadow some internal medicine, some hospitalist work. So I think that helped me be more comfortable because I'd been on a ward for 10, 20 hours or so over the course of last year. So I kind of knew about the nursing station, how the physicians walk around. And so I felt a little bit more comfortable. I felt like an imposter because of what I was about to do. But just kind of hanging out there, I had this level of comfort, which I was able to develop just from exposure the previous year. I found my patients. When I went to see my patient, they were sleeping. They were fast asleep. And I just kind of was like, oh no, they're fast asleep. I'm looking at them and I'm thinking, I have no idea what they're going through. I have no idea what kind of night they had. Maybe they were awake all night in pain and they just had managed to fall asleep half an hour ago,
Yep.
And here I am, medical student walking in who's doing something for the sole purpose of my own learning, not to benefit them whatsoever. And now I'm going to wake them up. You know what I mean? Do you know what I mean? So I felt I was petrified to wake them up. So I sat there for a while, just in the room, kind of watching them sleep in a non creepy way, of course, in a non creepy way. Just kind of like, what do I do? What do I do? Do I shake them? Do I say, hey, wake up? I didn't. That's where I really lost my courage. But eventually, I know I have a certain cutoff time. I'm gonna have to go present to my tutor. So I was like, I have to wake them up. So I kind of like touched their leg gently, like, hey, wake up, and they started to stir. It's maybe like a middle-aged woman, and they're not into waking up. Like go away, kind of pushing away my hand. I want to sleep. Like don't wake me up right now. And I was like, oh no, what am I gonna do? But thank God I was so early. I was like half an hour early for my session. And so eventually they started to stir. The light came through the window and they started to kind of wake up. And then I tried to initiate conversation. And so my initial learning experience was nothing that they teach you in terms of taking a history or doing a physical exam. It's just a real human interaction. Like what do I do with this? How do I get this person engaged in a conversation, actually want to talk to me?
Mm-hmm.
So I kind of like I was okay, I can get them breakfast. So they were kind of starting to hand out food, so I went to get her the breakfast and the tray. Said, "Here, breakfast. Are you hungry?" And I kind of she eventually stirred and sat up, and I brought the food to the table. And I said, we're just gonna have a really casual conversation. You can eat your breakfast, no pressure, and just tried to create this environment of them feeling very comfortable. And so as they started to eat their breakfast, then I just slowly, started asking questions without making it seem too much like a checklist, but kind of just just casual conversation. And so that was kind of my way in. That was my way in. And but the conversation that she was very succinct with her responses. Was not wanting to elaborate. It was very difficult to reciprocate conversation. So that was an obstacle that I was dealing with. And as I proceeded through the history and physical exam, my main reflection was it was such a learning experience, because how to do a history and physical in a patient that's admitted in the hospital is something that they don't teach you. in our clinical skill sessions. We get the privilege of practicing on very compliant, very cooperative patients who are not currently sick. So in this simulated situation, you get to practice. Ask them the right questions, physical, but you have 100% cooperation. And as soon as you're in the hospital, now a patient's actually sick. And there's such a diversity in experience in what brought the patient there, and so in doing so, you have to learn all the tricks and the little things. Like, you have to actually ask the question, how am I going to get through this history and physical? Like, it's not can I remember everything from the checklist? It's like, how am I actually going to get through this? Because of patient compliance and cooperation and maybe their state of health and so on. So that was my main takeaway from seeing this patient. I just wanted to share that. But let's get into the case.
Sure.
So, she's arousing. You're starting to talk to her, and you find out this is a 60-year-old woman who was of West African descent and moved to Vancouver just over 20 years ago. She really doesn't have much significant past medical history, but she notes having an abdominal surgery a few years back, and she remembered that they removed something, but she's not able to tell you what. She's not able to tell you what they removed. When you start to talk to her, you find out that she's been in the hospital for about 4 days, and the reason why she came to the hospital in the first place was kind of abrupt onset, severe left-sided pain. She just described this severe pain on the left side of her body. She was able to kind of deal with it for about 30 minutes, and the pain was so overcoming that she called her sister and asked her sister to bring her to the hospital. When she was admitted, from what she can remember, she can tell you that she was having difficulty ambulating because of the pain, but also feeling a bit dizzy and feeling weak. Kind of like weak, dizzy, in a lot of pain, just not feeling good. And so, yeah, difficulty ambulating. They were kind of pushing her on the wheelchair. And she ended up being admitted to the hospital, obviously.
Mm-hmm.
You find out that she was admitted with a fever, to which they were giving her antipyretics. And the nurse told me this. So I kind of got a little bit more history there than maybe I would have otherwise. But since then, the fever's come down, and when you see her, she's afebrile and no longer on antipyretics. She does think that they gave her some antibiotics through the course, and she said they did some kind of procedure on her, but she's not able to give much information on what this procedure is like. When you ask more about how the pain was characterized, she described the pain as like a knife, a stabbing pain. Relatively constant, and it has improved in the days that she's been admitted, but she can still kind of feel it there. She's never had this kind of pain before. It doesn't radiate anywhere in her body. She kind of just touches her left side and says it's around here. Never had this before. Never had this kind of dizziness as well, and she says she's never been so dizzy. She's lost consciousness, etc. In terms of what might have preceded the pain, like, she denies any trauma. She didn't fall. She denies any kind of other trauma that might have happened. She denies any illness that she knew about. Although it's very interesting, if she was admitted with a fever, we asked the question, well, weren't you sick, or? But she was not really aware of being sick. Also, while in the hospital, she's on bolus insulin, although she says that she doesn't have diabetes. And she's also on normal saline fluids, and you get the sense that she has been kind of daily since she's been at the hospital. She's also constipated, and she says this is something she deals with outside the hospital, but it's been worse now that she's in the hospital. And you find out that they've been giving her polyethylene glycol liquid, and that she's been having throughout the day and with meals. Seems to be helping a little bit, but she's still having difficulty having bowel movements, but it's not zero. She says someday she's able to have a bowel movement. I'll give you just a little bit more history. She's having no other like focal abdominal pain and no nausea, like no diarrhea. She hasn't vomited. There is no bloody what do I call it? I was
Milena?
gonna use a word. I was gonna use a word for like just secretions out of the body. Like there's no
Oh,
hematemesis, no
no.
melena, no hematochezia. There's no blood coming out of any of her orifices.
Okay.
Say it like that. And yeah, she said in the past, like just in terms of the past, she might have had these like paresthesias off and on, but she can't really say. Um, and yeah, I'll kind of leave it there. That's her story.
Mm.
Um, what are some of your initial reflections, and what are some things that you would be curious about that I didn't mention, and what's going through your mind when you hear that?
Yeah, you mentioned it was left-sided pain. Was it just her entire entire left side of her body?
No, it is her trunk, limited to her trunk area. Kind
Oh,
of like
okay.
we're thinking like mid axillary line,
Hmm.
maybe just under the axilla and stops before the iliac crest. But it's before examination, hard to know exactly.
Okay. Yeah.
Yeah.
I mean, at first I thought it was quite strange because, well, just left-sided pain. Maybe that would be like neuro related. Um,
Hmm.
but now that it's in the, I guess you said it was its trunk becomes a little more focal, right? So maybe something abdominal, something in
Hmm.
the abdomen, or maybe it's affecting yeah, multiple dermatomes. I still think neuro is possible, but it's quite unlikely.
Yeah. Yeah. So we're thinking maybe we're abdominal, maybe it's GI, or maybe it's kind of abdominal but non GI. Maybe it's retroperitoneal, etc.
Hmm.
We're thinking maybe it's neuro. Interesting how we have to like the first time as I was hearing this story, definitely running through my mind is, are these all a part of the same problem?
Yeah.
It's always an important question to ask. Um, and once again, when we're just hearing on history, we always have to not, we want to trust our patients, but we always have to keep in the back of our mind, people could be remembering things wrong.
Yep.
Even if you ask me, hey, what did you do on the weekend? I might not be able to tell you accurately. We know what I did. So yeah, we have to, everything on history needs to be taken with a grain of salt.
Hmm.
And when I'm hearing these constellation of things, okay, she's got the left-sided pain. It's severe. It's so severe that she's like, take me to the hospital. But she's also febrile on admission. She also has this weird kind of non-specific weakness, paresthesia, um, almost pre-syncopic presentation, which is interesting. And then you have to ask the question: are these all a part of the same thing? Did she have? So what I'm thinking when I see the patients, like, did all of these, did they start at the same time? So was there congruency between the left side of pain and all of a sudden feeling weak and hot and febrile, etc.?
Hmm.
Or was he kind of like already sick and like maybe didn't notice, or maybe just didn't describe it to me in that way, and she was kind of had the fever for a few days, not feeling great, and then kind of the abrupt left sided pain. You know, I'm seeing on day 4. I'm really curious about how sick she was on day 1. She said she had a procedure. Did she have maybe she had a bowel perforation? You know,
Yep.
acute onset left-sided pain. Maybe it's splenic flexure. You're always thinking about like spleen area, descending colon, left side. Thinking about the structures there. Did it have a bowel perforation? Now it's like peritonitis, fever, left-sided pain kind of situation. I don't know. I'm seeing her on day 4,
Hmm.
and she's giving like 3-word responses, so it's very difficult to know. So that's obviously I'm thinking about, was this really a crisis when she got here and now she's stable? So I was thinking that, as I'm approaching my physical exam, I'm saying I really want to, palpate the area, see where the soreness is, see if I can, maybe it's splenic, maybe I can palpate a large spleen. Really kind of curious to do the abdominal exam, of course. And yeah, I think my mind was in a similar place as yours. Is this, is it located to the abdomen? Is it focal? Could it be neuro? Will it have a dermatomal distribution? Although she denied like these shooting pains. I don't have reason to believe right now it's kind of spinal in origin, like a radiculopathy sending shooting pain. It doesn't shoot, doesn't radiate. It just kind of like feels like a knife is in my side,
Yeah.
Right. So that's kind of the picture. I'll give you a little bit of the physical exam and then see where we go from there. So like I said, when you see her, she's mildly cooperative. The patient she's kind of subdued. She's alert, she's oriented, but has this subdued demeanor, giving very short answers. You almost describe her affect as being flat, but not confident to like be psychiatrically diagnosed as a flat affect, but definitely has this kind of phenotype. When you see her, she's a woman of West African descent, and she's a dark skin color, and she's thin, but definitely not cachectic, definitely not emaciated looking like the patient that you presented to me, but definitely thin, definitely a bit slow moving, looking a little bit weak, but not acutely ill in any way. And her so we get it. Her vitals are notable. She does have a blood pressure of around 150 systolic, maybe like 150 over 100 blood pressure. Her heart rate, she's tachycardic, is about 112 BPM heart rate. She's afebrile, temperature is 35.5, and she's satting 99% on room air. I did not document the respiratory rate. So just to summarize the vitals, she's hypertensive, not with a diagnosis of hypertension, but blood pressure is starting to push a little bit higher than what we would consider normal, but definitely no acute issues with the blood pressure. It's not at 200 or et cetera. And she's tachycardic, although even though she's completely at rest and not exerting herself.
Mm-hmm.
But, when I'm seeing these vitals, I'm also thinking, this person, maybe we know that pain can be a sympathetic outflow stimulant. You just being in a lot of pain, you can get tachycardic and tachypnic just from pain. She's also just gotten over a fever, a little bit pushing blood pressure and high heart rate is totally congruent also with someone who just had a fever. The physical exam, I'll just go through it here. It's notably quite normal. I'm going to give you the positive findings first. I would say the most pertinent positive finding was extreme tenderness on the left side, particularly when you palpate, let's say, the lower few ribs, that area, and on the axillary line, not the lower few ribs, kind of like midclavicular or over more of the anterior abdomen, but really this kind of mid axillary line, right on the side of the body. Lower 3-4 ribs, I can barely touch them, and she's guarding. She's kind of yelping out of the way because she's in so much pain in the lower few ribs. And the other pertinent maybe finding was the lower conjunctival or conjunctiva were quite pale, and also mucous membranes look a little bit dry and pale as well. Although otherwise the skin is warm and appears to be well perfused. She's got good cap refill, etc. So those really are the big pertinent positive findings. Other than that, the exam is really grossly normal. You look at her head, eyes. Pupillary reflexes are totally normal. No pupillary defect. Not that we're expecting that right now. No lymph nodes that you can palpate in the head and the neck. It didn't perform a fundoscopy. Like I said, the mucosal is just maybe a little bit pale, but no thrush, no lesions in the mouth. The auditory tube in the ear, unremarkable. JVP, I would say the JVP, I was able to visualize it could have been a bit low, although I didn't directly measure it. It could have been about 1 centimeter, which, is congruent with the fact that she's receiving IV fluids. She could be a bit volume depleted, but after 4 days, you would suspect that they got it a bit more normal, but JVP might be still a bit soft. Her pulses kind of like everywhere the pulses are palpable, but a little bit soft. Like you can palpate them, but not easily. But also, I heard from a nurse that she had in her venous line, they had to kind of get a different attachment because, as the nurses describe it, she had very deep veins. They were hard to access. So I don't know also about arteries, but the soft pulses could be congruent with this idea that her vessels are kind of less superficial than the normal. Respiratory exam is totally normal, as well as the cardiovascular, except of course the tachycardia. But the auscultation of the precordial areas is completely normal. Abdomen, once again, surprisingly unremarkable, except for the left lower rib tenderness. You examine the abdomen, it looks completely normal. There are no skin changes. It's flat, soft, non-tender throughout the abdomen. Superficial, deep palpation. She's totally fine. You can appreciate a large midline scar, which is congruent with her history of the abdominal surgery from a few years ago. But other than that, totally normal. There's no costal vertebral angle tenderness. No flank tenderness. Otherwise, I didn't perform a digital rectal exam. And just kind of to finish off, neurological exam was completely normal. Cranial nerves grossly intact. Since peripheral, I didn't check reflexes, but strength was there. She seemed a bit weak, but she could totally resist the main muscle groups. She could resist my force. Sensation was grossly intact as well. That's about it. What do you think now? I could give you a bit more, but I could just be telling you this is normal, this is normal, this is normal.
Yeah. It's interesting. I feel like well, even from the beginning I didn't really have like a good working differential, but now after you give me the physical exam, so many things seem normal, and it's just this tenderness at I guess you said it was one of the lower ribs or spanning some of the lower ribs that is the only abnormal finding. And so it has to involve some sort of very focal process, not like as you mentioned, things like pericarditis, or you mentioned peritonitis. Even
there was
splenic
no
rupture
rebound tenderness.
Yeah.
Oh, just to interrupt quickly, to do with the spleen, I couldn't appreciate any splenomegaly, at least by palpation, and I forgot to do that one physical exam sign that they teach us, which is the Castell's sign with percussion. I don't know if she would have let me percuss that area because that's right where she was. It's right over where she was hurting the most, and I don't know how sensitive that test is, but that could have maybe given me an idea if the spleen was enlarged, but I didn't do it.
And it wasn't radiating anywhere, and she had it for how long?
It admitted for 4 days.
Okay, but
and she said that it was acute onset, so she didn't have it before that. So let's call it 4 or 5 day history. 30 minutes. It was 30 minutes until she said, "I need to go to the hospital."
Okay. Yeah, that is very strange. I'm thinking maybe I was initially thinking something like a stone, but a stone doesn't evolve that quickly, right? And if you had like a splenic rupture, there should be a history of trauma there, and you should have like sickle cell disease. She is the right demographic for that. But if you have a ruptured spleen, you should expect radiating pain because the contents irritate the diaphragm, leading to irritation along C3, C4, and C5, of course. But this is very localized, so I'm not quite sure.
Yeah, it's interesting. Hey, and I'll just before I give my thoughts, I guess just a little bit more history. Like I said, the past medical history is non-contributory, other than the abdominal surgery. She's on no medications. She said no allergies. She reports being up to date on immunizations. Family history said father died of old age. Mother may have had hypertension, may have died of a heart attack, but she can't remember.
Mm-hmm.
There's no other known family history of any pertinent medical conditions. That's about it. I told her, I told you about the immigration. She has a stable job, housing. She has her sister and 2 children in town. She's not currently with her sister. Sorry, her children's father is not in the picture. Um, but she reports feeling well, socially supported. She no alcohol, drug use, tobacco. She reports being physically active, balanced diet. So
Mm-hmm.
none of those other factors seem to have help us in help us in any way. Neither did the review of systems. She kind of just denying everything when you do a review of systems. So my final thoughts on this case, I don't have a diagnosis. I wasn't able to see labs. I wasn't able to, as a part of the normal session, we're not able to talk to the attending physicians. I was able to get some brief information from the nurses, like I mentioned, but we're not able to talk to the care team
Mm-hmm.
at large. So after I reflected on the case a bit more, I came up with a couple potential ideas. I love your idea about sickle cell. Like you said, she's the right demographic.
Right.
And we also
Vaso-occlusive
have
pain syndrome, right?
like a vaso-occlusive pain syndrome. We have the kind of the perisplenic severe pain.
Yeah.
We have the potential anemia with the pallor in the mucous membranes and the and the palpebral conjunctiva.
Mm-hmm.
So let's take it for granted she's anemic. She got this kind of sudden onset pain. The sudden onset pain is congruent with vaso-occlusive syndrome, like you said. It can localize to the spleen, although you said it should radiate, but maybe not always, maybe not in 100% of
If
cases.
it ruptures, then it should radiate. If it's just vaso-occlusion, I think if she does have sickle cell, I would say this is vaso-occlusive crisis.
Mm-hmm.
But it
Right,
seems like
right.
she doesn't have it, so I'm not sure.
it's
Well,
a, it's still I would keep it on the differential before you
yeah.
see any labs, but I think that's one interesting idea. Another interesting idea is I did some reading. You can have, so speaking of demographic, I just go back within this demographic,
Mm-hmm.
60-year-old female, West Africa. You could have a kind of flare up of malaria that occurs even decades after initial infection. And it could be a unifying explanation for fever, splenomegaly, or perisplenic pain,
Yeah.
and anemia. So that's one interesting possibility.
Mm-hmm.
Other than that, you're just thinking you're on your upper left quadrant abdominal pain differential. You're like, is there diverticulitis? Is there perforation? And is there some kind of splenic pathology? But once again, some kind of words, a splenic pathology. Maybe there's an infiltrative disease. Like I said, maybe there's some kind of vaso-occlusive disease. But okay, vaso-occlusive, we would think about being acute, but other splenic processes we wouldn't think about as being such like acute onset pain. What do we
Mm-hmm.
say? And the spleen's growing, growing, and then all of a sudden it reaches some kind of critical threshold, and all of a sudden it hurts really bad. Maybe. So overall, a very puzzling case.
Mm-hmm.
I think in the end, if what I would keep on my differential as I approach labs, I'd want to, you'd want to get a CBC. You want to see if they're anemic, if there are signs of ongoing infection, are their white counts increased, etc. I mean, I would imagine that management, we're going to image this lady right away. We're going to get an X-ray to rule out, costal fracture. Um, I really hope it wasn't this case, but we always have to entertain the possibility of trauma with this acute onset. Maybe there's something that she wasn't telling us. Maybe there was some kind of traumatic incident to the left side of the body. So we would X-ray. I think we'd be pretty quick to CT to do a CT abdomen. I'm not sure with contrast or not, but you'd want a CBC. We want to image kind of right away, and I think that would really lead you. Into a more narrow path of diagnosis. But yeah, those are my reflections. I'm thinking left upper quadrant abdominal differential, like you'd give for anybody. Then you kind of have the unique explanations based on demographic, like we said, that might be some kind of sickle cell complication or sickle cell disease, and maybe very interestingly, if it would be a kind of a late onset or relapse of a malaria infection.
Yep. That was interesting. Thank you. It reminds me of the fact that medicine is so localized, and it has to be, right? You're not going to learn about malaria here or leishmaniasis or what's it called, Lyme disease, because those are not really that common here. We might learn it like in passing, but it's not that useful. Whereas if you do medicine in, say, Nigeria, of course you're going to learn about malaria. Of course you're going to learn about the entire life cycle of the parasite and how it can present in all kinds of different ways. And of course, in the East Coast of the U.S., you're going to learn about Lyme disease and ticks and all of these kinds of bugs and deer and whatever vectors they have. And in Japan, just a last example, they learn a lot about fish-borne parasites. So because people there eat a lot of fish, and so medicine is so localized, and it's kind of interesting to see these cases. I guess it's part of the appeal of specializing in something like micro or infectious disease, where you do see all these weird and wonderful things. But every so often, it does come up even in, I guess, non-infectious disease specialties or fields. I'd be curious to know what this person has.
I'm still dying to know. I'm still dying to know. Just show me the CT, or And I was talking with a fourth-year medical student, one of my friends.
Yeah.
I was also telling him about this case. And I mentioned the same sentiment. I said, I'm just so curious to know, and I think it would be a great learning point for me to actually be able to see some of the lab's investigations and maybe even diagnosis. But he argued a couple of points, just to play devil's advocate as well. Obviously, he admitted that it would be exciting to hear the final diagnosis. But he said, at our level in second year, and this is our first time ever doing this, really it's just about going through the exercise of doing a history and physical. Can you get through it? He was questioning the idea of, if you heard the final diagnosis, would that actually help reinforce your learning of how to do kind of thorough physical, a history and physical?
Yeah.
And he's also saying that it's also a little bit above our level right now. We are expected to just be able to go through the process of taking this thorough history physical, and the management piece is not quite at our level. That was one. And he also said it's totally unfeasible to have the second year medical students come in and start to interact with the care team and talk to the attending physician and so on. That's for third, fourth year. And it's not feasible. He said it's not feasible. It's above our level, and it's going to have minimal impact on our learning in terms of just doing a thorough history physical. And I thought that was interesting. But regardless of what he said, I'm still very curious, and I would still love to know what the final diagnosis was.
Great.
Well, that's about an hour. I know we have 2 more cases, but I think we should. I think we'll leave it there, and we can save our other cases to discuss another time.
Sure. Or we could do this. I don't know if you want to. I actually, let's say you know a diagnosis. We can just play a game. You try to guess. You just keep asking me yes/no questions until you get to the diagnosis. You want to do that?
Yeah, we can try and finish with that.
Okay. So
I don't know how I'll do this morning.
Something easy. Like, start very broad. Like, is it do they go to surgery? Do they go to internal med? Is it this? Is it that? Something like that. And okay. This is my second CSI case. So I'll give you a bit of demographic, and then you can start asking questions. So this is a 45-year-old female. She has been in hospital for 1 week. She underwent surgery 4 days ago.
45-year-old female, hospital for 1 week, surgery a few days ago. Do I get to ask questions like, as such, questions like, what kind of surgery did she have? Am I allowed to know that?
Sure. Yeah. This is a pretty complicated one, so let's do that.
Okay, what was the surgery?
It involved placing grafts.
Skin grafts?
Nope.
Okay, something under the skin. Let's just go back a few steps. Do we know the initial reason for admission, or the symptomology that was the cause of admission?
Yes. Oh, I should just say yes, no. I'll stick to it. Yes or no?
Were they febrile on admission?
No.
Were they in pain?
Yes.
Was the pain diffuse or focal? Or no, I guess not a yes or no question. Was the
Yeah.
pain diffuse?
No, not diffuse.
Okay, it was focal. Just ask a few. Was there pain in the anterior side of the body?
Yes. Yes.
Did they have chest pain?
No.
Abdominal pain?
Yes and no. Yes. Yes.
Pelvic pain?
Kind of. Kind of.
Okay, and any pain in the extremities?
Yes. Yes.
Okay. Lower extremities?
Yes.
Upper. Okay. And are we talking like hip to toe?
Yes.
Okay. Was it severity more than 7 out of 10?
Yes.
Okay, so you have 45-year-old female presenting with severe lower extremity pain that may or may not be present or radiating in the pelvic, maybe lower abdominal region, who is afebrile, and been in the hospital for a week. Were there any visible skin changes on admission?
Yes.
Were the skin changes ulcerating?
No.
Any superficial signs of venous congestion?
Kind
whatever.
of. I'll say no. It's mostly no. It's more of a no, yeah.
Any inflammatory phenotype, red, hot, swollen?
Acutely, yes. So at presentation.
At presentation, yes. Okay. Are there any, can we appreciate any like macules or papules or well circumscribed discrete lesions?
No.
Okay. It's bilateral.
Kind of. More no than yes.
More no than yes. Okay. Is it more on the left side then?
No.
Okay. More on the right side.
Yes.
Okay. I guess, is there any significant past medical history that doesn't give it
Yes.
away? Is that cheating?
No.
No. I guess I'm still at yes or no, hey?
Yes.
Any recent history of infection?
No.
Okay. Any history of hypercoagulability, embolic events, cardiovascular disease?
Yes. Big yes.
On the cardiovascular disease?
Yes. Well, all of these.
Okay. Currently being treated or before admission being treated?
Unclear.
Unclear.
Yeah.
Okay. So my limited knowledge as a second year has really come out right now, but I'll tell you how I'm framing this in my head so far, instead of me just asking seemingly random questions, which is what you do when you're floundering. So I'm having, right-sided, or like really severe, let's call it mostly right-sided,
Yes.
lower extremity pain. Initially, looking inflamed, red, hot, swollen, without discrete kind of dermatological lesions, without obvious signs of venous congestion or, like DVT. And we have a history of cardiovascular disease, unclear if being treated. There was no preceding infection. I'm assuming no trauma.
No trauma.
I'm assuming no trauma. So I think when you have left lower extremity, severe pain, inflammation, cardiovascular, potential cardiovascular causes, or a background or a background of cardiovascular disease, it is an important question to ask if it's unilateral or bilateral. Maybe I'm not going to have an eloquent answer for this. We're in things that can make the leg acutely painful. We're thinking about an inflammatory. We might entertain a kind of cellulitis idea, or like a myositis. Maybe she could be having a. I know we're kind of out of cardiovascular territory, but I'm thinking about acute inflammatory unilateral differential. Why don't you help me out with a few ideas
Yeah.
of that category?
Let's autoimmune is great, but stay on track of cardiovascular, because myositis, polymyositis, dermatomyositis, they have other manifestations. They tend to be more like muscle ache, muscle weakness, soreness, that sort of thing. Not this super acute presentation. And I'll give you another description of the pain. Yes, initially it was kind of inflamed, but don't focus on that. The main
Right.
thing was that the pain was relieved by rest and exacerbated by activity or exertion.
And what's the fancy name for that?
Starts with a
You're doing some
C.
the claudication?
Yes.
Right. So he's having claudication.
And then also, big clue is significant family history. So her mother had an amputation of the right leg at around age 30, and her daughter
Wow.
also has similar symptoms beginning at age 28.
Huh. Once again, my limited knowledge is gonna is gonna show here, but
You basically said it
that's
in one of your questions. You mentioned it
I did.
in the same sentence as cardiovascular.
I said embolic, didn't I?
The one before that, you said hypercoagulability.
Yes, I did.
Yeah.
I did say that.
Yeah. So she has what we think is a familial hypercoagulability, and because there are no signs of venous congestion, that means it is arterial. And so physical exam shows things like diminished distal pulses, pale extremities, sparse and patchy hair distribution, slow capillary refill, and her entire body was just cold. Like
Yeah.
she looked healthy. She was mentating well, but she was very pale, very cold. She didn't seem to feel cold though, which I thought was interesting. But anyway, we're not sure what it is. She
Okay,
says,
so we have.
"Oh, sorry. Go ahead."
No, just saying. So I'm kind of just to summarize in my own mind.
Mm-hmm.
45-year-old female, strong family history of. Can we say family history of hypercoagulability, or that's what we're
Yeah.
suspecting?
Yeah.
Mother had to have her right leg amputated. Sister also had quite early onset.
Oh, daughter.
Daughter also has. Daughter also has a similar symptomology. What did you say? What age did it start?
For the mother, she had her leg amputated in her early 30s, and her daughter has similar symptoms beginning at age 28.
Okay. And like you said, there's no sign of venous congestion. So we're thinking about arterial issues, arterial hypercoagulability. We have issues. We have defects in peripheral perfusion, and we have the claudication, which makes sense. What happens when you ambulate? What happens as you increase oxygen and blood demand in the peripheral musculature? Well, if you increase demand and you don't have the means to meet that demand or increase the supply of oxygen and blood, you're going to be met with pain. Is this kind of like are we calling this like an angina of the legs, as we get almost this like ischemic effect of a supply demand mismatch? That would be an interesting question. I don't know what I think about claudication. I'm thinking about that effect. We can all get sore muscles as we like really work out hard. As the buildup of kind of as it gets really acidotic is the thought. And like if you have you have an arterial problem limiting supply of oxygen, mainly oxygen, of course, and blood, is that causing kind of a similar phenomenon? That would make sense. Hypercoagulability, now I got to think about what? We think about a hypercoagulable state. We're not thinking pregnancy because we have this kind of familiar pattern, familial pattern. Also, we're ruling out, like things like malignancy that can cause a hypercoagulable phenotype just because of this kind of familial distribution. So when I'm thinking about this familiar pattern, I'm thinking about hypercoagulability in arterial. I'm thinking about the innate coagulation factors that are in the blood. I don't know if I'm on the right track. You could be hypercoagulable for different reasons. I'm not going to be able to give a very eloquent explanation, but I'm thinking there are anticoagulation factors. Maybe you can have a deficiency in those, and I don't know whether or not in terms of the coagulation factors, if you can have like an excessive amount of those. So I'm thinking either two, you're being hypercoagulable because you have an excess of coagulation factors, or you have a deficit in anticoagulation factors. That's where, and something that's of course heritable, genetic. I'm thinking about the genes that code for these different proteins and enzymes that are involved in the cascade. Am I on the right track?
Yeah, it was on my differential. It was at the top of my differential. Well, my differential was a bit weird because nothing seemed to fit, right? And let me explain why. So you mentioned hereditary thrombophilia is due to coagulation factors being high or low. So for instance, protein CRS deficiency, antithrombin 3 deficiency, factor V Leiden, which is actually right for this demographic because factor V Leiden is very common, or most common in Caucasians. This is a Caucasian patient.
And these are deficiencies in anticoagulation factors.
The deficiencies are, and then factor V Leiden is a stabilization. So it makes factor V unable to be cleaved by protein CNS.
Right.
But the reason why this is inconsistent is because if you remember, venous embolism or venous thrombosis involves a different pathophysiology than arterial thrombosis, which is why we give aspirin or antiplatelets for instance, atrial fibrillation instead of DOACs for long-term prevention, that is. Right. And the reason that the way I like to remember it is venous circulation is slow moving. It allows the secondary coagulation cascade to happen, whereas arterial blood has higher pressure, higher flow rates, and therefore it's going to be thrombosis in the arterial circulation is driven primarily by platelet problems rather than coagulation factor issues. So the fact that, she could have one of those platelet problems, but those platelet problems usually cause decreased coagulation rather than increased coagulation. So for instance, GP2B3A deficiency or GP1B deficiencies.
Now we're thinking about more. We're expecting her to have more of a bleeding disorder in this case.
Yeah, well, that would be for deficiency. What I'm trying to say is that I don't know of a platelet disorder that would cause increased thrombosis. Do you know what I mean?
Yes.
But coagulation factor based hereditary thrombophilia is still on the differential, but it was hard for me to think of like what else could be the issue. We've learned a little bit about antiphospholipid syndrome, but again, that also tends to be venous rather than arterial. And this patient has also had many specialists follow her according to her, so like rheumatology, cardiology, etc. And apparently nobody has been able to find a cause. So we don't really know what is the issue, but I think the one-liner description is hereditary, potentially autosomal dominant thrombophilia leading to chronic severe peripheral arterial disease with episodes of critical limb ischemia.
Wow, fascinating. Makes me feel a little less bad about stumbling through that one. If
No, I think you did very
even
well.
oh, thank you. It didn't feel like it, but I was also thinking about in this case, is it possible that that she can get some kind of, we learned about the microangiopathic hemolysis
Hmm.
and the kind of the family of different presentations where we have microthrombi, or very small thrombi forming in small vasculature that start to shear red blood cells, and it can produce an anemia.
Hmm.
Was there any sign of this, like in her presentation or history, that this kind of that the coagulation disorder that she has might lead to some kind of microangiopathic event? Or are we thinking more of the larger vessels?
I think it's going to be, I don't think it's MAHA or
Yeah,
microangiopathic hemolytic anemia, because
yeah.
she doesn't have things like purpura, petechiae, bruising, history of mucocutaneous bleeding, or etc. There were really no skin changes besides the pallor and coldness and those sorts of things. So no livedo reticularis, no splinter hemorrhages, no ulcerations. So I don't think it's MAHA. And then it's also not generalized. It's very localized. So it seems to be just, a thrombosis or thromboembolism that's affecting the femoral artery and or the iliac arteries. And she did end up having
And more
grafts.
and more so on one side. So fascinating.
Yeah, well, she did end up having symptoms on her left as well, but it started on her right, and that
Right.
it could potentially reflect some sort of some sort of difference in the anatomy. I do remember that there's a difference in anatomy in the iliac arteries on the right versus the left. That could potentially explain this, but perhaps we can review that tomorrow when we're in lab.
Wow, that's an absolutely fascinating case. And I'm assuming the graphs, like we're talking about just arterial graphs.
Yeah, so it's actually quite unfortunate because she's had multiple surgeries. She's been in hospital for this several times, and each time the interventions have failed. So she's had 4 grafts put in, didn't work. She had a bypass from her, I want to say, right brachial artery to her iliac arteries, and that got occluded as well. So they took it out, or sorry, they didn't take it out. They just, I think they kept it in, but cut it or something so that it wouldn't affect her. But it's still there, and you can palpate it as well. And the most recent surgery she had was a new graft made of some sort of biosynthetic material that might be less prone to thrombosis. I'm not quite sure. Apparently, she says it costed like $50,000. I don't know.
Wow, wow, wow.
Yeah. So
Fascinating case,
it's
and
something.
very unfortunate.
Yeah. It's hard when you can't give an answer, right? Like you can't pinpoint, oh, this is what is causing your disease, and thus this is what we're going to do for it.
Yeah.
Especially if she's undergoing so many of these invasive procedures time and time again, and it's just not working. Like, yeah.
Yeah. Fascinating. And gives us a preview to what we have in store next year, year 3. Clerkship, clinical years for the med students. Just get out of the furnace into the fire kind of type situation. But that was a great episode. I enjoyed discussing the cases. I learned a lot from you. And why don't we sign us off until next time? We are planning to have some guests on the next few episodes. If you're listening, expect some guests. I believe the first guest we're going to have on is a family doctor by training, who now does more health, wellness, private medicine, and aesthetic medicine. And we're excited to talk to him about about ways in which the healthcare system could expand, like things that are not covered under the socialized or under the government. Let me try that again. They're not currently government funded, but may actually stand to benefit the population if were. That's the space he lives in, and also how aesthetic medicine can actually be considered a much more in line with traditional medicine than some people might give it credit for. All right, give us a jingle.
Okay. Jingle, jingle.
Jingle, 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 jingle.
Yeah.
Do I do
Do you want me to? Okay. No, I can do it.
All right.
Okay. So that was Two Guys in Scrubs. If you want to support the podcast, leave us a like or review wherever you listen to your podcasts. Thanks for listening, and see you next time.
Boop-a-da-boo.